Hi everyone, this is my coagulation video, part 2, and here we're mostly going to be talking about the medications. So these medications that we have in front of us right now are either anticoagulants or antiplatelets. So we have heparin, enoxaparin, warfarin, and Plavix, and they are going to show you the similarities because they have very many similarities as far as their goal, nursing implications, and contraindications, labs, and so on. So the goal for all of these medications is to increase circulation, perfusion, VTE prophylaxis, and then also slow, blood clot growth. Okay. And remember, we talked about the coagulation cascade. And so these all interfere with the coagulation cascade, which means we have less clotting factors in our body, which means we're able to bleed easier. Okay. Important note there, less clotting factors because these are trying to interfere with those clotting factors, and then we bleed easier. So with that in mind, one of the major adverse effects for this is bleeding. We're going to be able to bleed more easily. Okay, so we need to monitor for bleeding. We can monitor for bleeding in many different ways. You can use your labs, you can use your blood pressure, you can use your heart rate. Your blood pressure is going to drop, your heart rate is going to increase, your respiratory rate is going to increase. If you have an upper GI bleed, you're going to have black stools because by the time it comes out of your rectum, it is old blood. So we're going to look for black stools, but we're also going to look for frank red blood stools if we have a lower GI bleed. Okay. We're going to look for neuro changes because if we're at risk of bleeding and we do have hemorrhagic stroke, then we're going to be bleeding out even more. And of course, anemia. So in order to monitor all of those, we are going to look at our labs. We're going to look at our CBCs, our platelets. We can do an occult blood stool test. And then we're also going to be looking at clotting times, which do differ with these. I spoke about clotting times in the previous video, and we'll be looking at clotting times here as well. So if you have a patient, you need to think ahead and think what's the worst possible thing that can happen to this patient and what do I need to be looking for? Okay. And also what caused the bleed. So for example, if someone is started on Coumadin, but they have a peptic ulcer, that's contraindicated because if the Coumadin is going to make you bleed, well, a peptic ulcer bleeds. And so that's going to increase the bleeding of the peptic ulcer and make it worse. So things like that, you need to make associations. Now, if you need to call the MD if the bleeding changes, if it increases, if it decreases, if there are changes. So if they don't have any black or red in their stool, and now all of a sudden they do, you need to call them and let them know this. Or if the black stool all of a sudden turns into frank blood, which is red blood that's very like active bleeding blood, then you need to let the physician know immediately. All of these things could become emergencies extremely fast. We also need to educate our patient on all of these meds. They need to, if they fall and hit their head, even with no outward signs of injury, they immediately need to go to the ED. They're probably going to need a CT because the quicker they get the CT, if there is a small bleed from that head fall, they might not notice signs and symptoms until hours later, and then it might be too late because there's blood then accumulating in their brain and pushing on their brain matter. And once there's any type of shift, it's very difficult to treat. If they have a cut that does not stop bleeding, to call their primary care physician, maybe if they're at home first, and then they will advise them on whether or not they need to go to the ED. Okay. because we have different kinds of cuts. All right, they might call them into their primary care physician's office first before going to the ED. Of course, if it's kind of squirting out, maybe it's an artery, different story, go straight to the ED. We want to help prevent them from getting bleeds. So using a soft toothbrush, so they don't irritate their gums too much, and they should be wearing a medic alert bracelet when they're on these medications, so that if they are in an emergent situation, the paramedics can see this and know that they're at risk of bleeding, and then the appropriate tests can be done if maybe they're nonverbal at the time. So let's talk about things that are contraindicated for the patient to be on some of these medications, and these are just a few of them. Peptic ulcer, which I just spoke about. Recent surgery, because you're going to have raw areas that could be having minor blood loss from the surgery itself, which is typically not a problem because we have our own coagulation cascade that is going to help stop that from bleeding. But if we are on any of these medications, we're inhibiting that from happening, and so we might not stop bleeding. Hepatic impairment, this is because of the synthesis of the medication itself and how we have our clotting factors typically from our liver. Uncontrolled hypertension. So I want you to think about this for a moment. Uncontrolled hypertension. If you have hypertension, uncontrolled being very high, and you have a hemorrhagic bleed in your brain because of the uncontrolled hypertension, which is an absolute side effect of uncontrolled hypertension, the bleed in your brain is going to be much, much worse if you're on any of these medications, because your body is not going to clot as quickly as it would normally or at all. So just as I said before, talking about neuro changes, this is where you would see neuro changes. Also a brain injury, of course, we're not going to put them on any type of medication like this when they have a brain injury because of the risk of bleeding. So even if the brain is swollen, doesn't have any cut openings or anything, they are still at risk. So remember, I want you to remember, these are all similarities of these medications. So as I go down these medications now, we're going to be talking about highlighting just the differences that each of these medications have. So first of all, let's talk about warfarin or Coumadin. That is in PO form only, and it is color-coded. Each dosage is a color. That is to make it easier for patients and easier for professionals as well when they are unsure about the dosage that the patient is actually taking. I will have a picture of you up for you on the Coumadin tablets in a later slide. And that is PO only. Now, heparin and Lovenox are both sub-Q, very common. The one difference between the two is that heparin is also given via IV. Okay, it can be given as a drip, possibly for someone that has pulmonary embolism. That is a very common treatment plan, is to start them off on a heparin IV drip. And we do that by monitoring the PTT, and we adjust our dosages, we titrate the IV based on the PTT. Some newer medications are Xarelto, Eliquis, and Pradaxa. These are excellent medications, more in the Coumadin warfarin family. And there are less side effects, less problematic for patients, because with Coumadin they have to go in and get blood checks usually every week. That changes a little bit depending on the patient and the physician, but they have to go to Coumadin clinics, get their blood drawn, and then they adjust their dosage for that their particular lab. So it's very time consuming and not very efficient for the patient, they don't like it very much. So Xarelto, Eliquis, and Pradaxa are very good medications. There's no labs for them, but they have fewer side effects. Okay, so let's talk about enoxaparin or Lovenox. As you can see, it inhibits blood clot formation. It's considered low molecular weight heparin. This is an anagram that you're going to see a lot, LMWH, low molecular weight heparin. This is used for a multitude of things. It's definitely used for prophylaxis in the hospital because the patient is immobile. So it's used for prophylaxis of DVTs, PEs, and so on. It can be used in conjunction with Coumadin as well because there's different mechanisms of actions. They work in different areas. This can also be used if you have a DVT and you are going home with treatment. Patients can be educated on how to give themselves a sub-Q injection of Lovenox. Typically, if you have a DVT, the normal course of treatment is 6 months to be using Lovenox until your body has dissolved the clot itself using its own fibrinolysis. There's no blood monitoring for this. It is weight dosed, and you could possibly get a APTT for this, but it's not very accurate. So we just look at dose weighting so that we can get the best effect. The antidote for this, as I said before, is protamine sulfate. So remember, this is enoxaparin Lovenox, but I told you that protamine sulfate, it should be remembered as P for heparin, heparin, protamine sulfate. But you need to remember that enoxaparin is in the family of heparin. So if you remember it's a low molecular weight heparin, then you have the heparin in there and you remember the protamine sulfate. Again, we're going to educate the patient on how to give self-injections, and then, of course, needle disposal. This is a Lovenox syringe. They are all like this. They come pre-measured, so if you, because it's weight dosed, if you might not need to give all of this dosage, maybe it says 60 milligrams or something, and you would have to squirt out some that you don't need prior to administering them. You need to educate them on all of this. This needle is just like a sub-Q needle, just like insulin, and so it's very small and very short and not an issue. So here's heparin. Inhibits clot formation, prophylaxis, and treatment. So it's prophylaxis just like the enoxaparin for DVTs, PEs, for AFib clot formation. I will actually put a video on Google Courses for you to see how a clot is formed when someone has the arrhythmia of atrial fibrillation. Basically, there's a little appendage on your atrium that should not be filled with anything, but when your atrium is not pumping properly and it's fibrillating, like quivering, then some extra blood kind of pools in this one area. And then if your heart goes back into a normal sinus rhythm and it has this nice big push of the heart muscle, then that little clot gets pushed out and into the ventricle and then into the body where it can cause problems. One of the adverse effects of heparin, and this would be really for long-term use, would be heparin-induced thrombocytopenia, which is a low platelet count. So for that reason, with Lovenox and heparin, we do monitor the platelets. Okay. We want to monitor the platelets, and again, with this heparin, we're going to monitor the PTT for prior to administering to make sure it is safe to administer. Prophylactically, this heparin we use is 5,000 units sub-Q. It can be daily, it can be Q12 hours. Again, the antidote is protamine sulfate. Now for treatment, we use this in an IV drip, and the dosage is depending on the PTT. Um, this is a double witness when we're talking about hanging IV drip, because there's 25,000 units in a 500 milliliter bag, and so we could completely overdose this patient and cause massive problems. So we co-sign, and there is a protocol on, depending on the labs coming back, usually every 4 to 6 hours, we adjust the dose. So it is your responsibility to make sure that the labs have been ordered and they're actually being taken and you're getting the values when you need them. Okay. Heparin is also a medication, just like Coumadin, where the bottles are color-coded. There have been a few instances where people have administered the wrong dosage of heparin because they have not read the labels. And that would be a nurse error and a medication error, because just because you get this vial out of the Pyxis in one particular spot all the time doesn't mean that it's going to be the same dosage all the time. The pharmacies have to change dosages and change little cubbies depending on what their availability is of what they can get for the hospital. So it is color coded now. However, you always need to read the label and see how much is it, 5,000 per ml, is it 5,000 per 2 ml. The standard is 5,000 per ml as far as the vial is concerned, and you doing sub-Q prophylactic shots, Q6 or Q4. I'm sorry, that, please excuse that. It's actually once a day or twice a day. So heparin prophylactics, this 5,000 units, is usually daily or BID. Coumadin. This is what I was talking about before up here. So when a patient comes in and you're doing their medication reconciliation for their history, and they'll say, "Oh, I don't know what Coumadin I'm taking right now, but I know it's the light pink. It's a light pink or the green. It might be the green tablet." So it's very easy to find out how many milligrams they're taking based on their color of the tablet that they're taking. Now this works on inhibiting, blocks the prothrombin to the thrombin again, but it also interferes with the hepatic synthesis of vitamin K. The hepatic synthesis of vitamin K. So because it blocks vitamin K, the antidote for Coumadin is vitamin K. All right, this blocks vitamin K, so the antidote is vitamin K. We give it a fair bit. So if their INR levels are slightly high, we can give them some vitamin K if really needed, to try and decrease their therapeutic range, which right now would be 2 to 3.5. So if they're getting into the 4 or the 5 range, then we're either going to lower the dose, or we're going to hold a few doses, or depending on the situation, we could give vitamin K, in which case is typically given as a sub-Q. Again, it treats PEs, AFib, clot prevention, management of MI, decrease of subsequent MIs and ischemic events. The majority of Coumadin out there is for patients that have current heart conditions and have a very high likelihood of either going into AFib or have a history of AFib and are on antiarrhythmics right now that are helping prevent them from going into AFib. That's the majority of our patients that are on Coumadin. They can go on it for a PE, but typically we'll give heparin or some of the other medications for PEs. But any type of heart condition where blood clots are a side effect, they're going to be on Coumadin. It's very common. However, like I stated before, it's not very convenient for the patient because they have to go get their INRs checked all the time. So it's a very strong and medication that can really adjust levels very quickly. The contraindications are the same as heparin. Here we monitor the INR. Remember, the INR is calculated from the PT. Okay, it's calculated from the PT, but it's a more specific lab for Coumadin. Foods high in vitamin K. So this is what you're going to hear. I'm on Coumadin. I can't eat any green leafy vegetables. That's what you're going to hear from some people. That is incorrect. Okay. What they do need to do is they need to um, eat the same amount of green leafy vegetables every day. They want to be stable in their amount of vitamin K foods that they're eating every day. Because it's an antidote for Coumadin, as long as they're stable, as far as, let's say, oh, I want to eat a cup of kale every day with my for lunch, or I want to eat broccoli with dinner every night. Well, that's fine. They can do that as long as it's consistent. What we don't want is if one day they eat lots of vitamin K rich foods and the next day they don't. That's the problem. Okay. Now, the more vitamin K rich foods that they do eat, the more Coumadin they're going to have to take, and that will be decided when they go to the clinics with their labs for their labs, and they'll be educated more in that as well. So as far as we're concerned in the hospital, we need to educate them on, until you go to your next lab, then for your next checkup, then you need to be very consistent. This is actually a medication where the pharmacists themselves in the hospital come and speak to the patient about the dietary factors that are involved with this medication. So that's another reason why some people don't like it, is because they can become very restricted to the foods that they might normally eat. And so, yeah, they don't like it because of that either. And the other ones don't have these restrictions. So remember the medications I talked about before, which was the Xarelta and so on. Those newer ones don't have these restrictions. Also, anise, chamomile, ginkgo, and garlic all increases the effect of Coumadin, and these are actually very common. A lot of people will drink chamomile tea. They have ginkgo and anise as a supplement that are in lots of multivitamins, and a lot of people eat garlic because garlic is good. Garlic is also good for your blood, good for your heart. So they're very restricted. I have given you here a list. I'm not going to go through them, but I'm going to give you, this is a list of the highlights of some of the things that patients and us have to be aware of when taking anticoagulants. This is the TPA that I was talking about. So we have alteplase and tenecteplase, or TNcase and activase. You will not be tested on this medication. I just wanted to kind of go over it with you just very slightly, because this is the medication that breaks down the fibrin that helps dissolve the clot. And these are the only medications that do this. Okay. It's a high alert, which means that the side effect for TPA, which is what we call this, is death, because you bleed out. Because it just tries to degrade all of the fibrin that you have in your body. So there is a major checklist that patients have to go through, or usually it's their family members, and not everybody gets this. You have to get to the hospital within a certain amount of hours. The quicker the better, otherwise they won't give it to you. And you must not have had any type of surgery or anything in your body that could cause bleeding, peptic ulcers, a GI bleed, just in the hospital for a GI bleed, none of that. You will just be dismissed from even having the medication. If you do get this medication, then by signing the form, you are understanding that the side effect of this medication is either that you're going to get better, or you might pass away. Okay. So this is nothing at all, nothing that you will have on the med-surg floor. If anyone is giving this on the med-surg floor, or if you're in the ER as a student, you cannot push this. You can watch and observe only. Okay. And then lastly is our antiplatelet medication. So, we've got, aspirin here, which is an antiplatelet medication, very common for what we call heart health. It just decreases the amount of platelets that we have in our body. If we do that, then we are less likely to form a little platelet plug that all join together and form a clot. We also have Plavix, clopidogrel, which is an excellent medication, not as bad on the GI system as aspirin is. Aspirin is an NSAID, and so it can cause GI distress and bleeding. Plavix does not cause that as much. They both inhibit platelet aggregation, as I said. Aspirin also has an additional advantage of inhibiting prostaglandins, so therefore they decrease inflammation. Both of these are typically used for a prophylactic. So if, and this is just going to be whether the patient gets an anticoagulant or an antiplatelet is just going to be at the decision of the physician and depending on labs, and that will be a choice made by them. But this is for prophylaxis as well for MI and stroke and so on because it helps stop platelet aggregation. So the labs for this are platelets. So we look at our platelets. So if you're going to give something that is an antiplatelet, or even a heparin for that matter, and the platelets are very high, then it would be warranted to give this medication. But if the platelets were very low, then that would mean that they would be at risk for bleeding, and so you're not going to give this medication. All right. Again, they have an increased risk of bleeding with anise, ginkgo biloba, chamomile, and ginger. Again, these are listed here because they're very common that patients might take. Hope you enjoyed the lecture.